Hello everyone and welcome to another day of high yield Usmle questions with me. Today we will be talking about renal. So let's talk about it. A 25-year-old male presented with prior history of HIV presented with maculopapular rash and fever. A few weeks ago he was treated with pneumocystis pneumonia with TMPSMX. So pneumocystis pneumonia is common in HIV, and you should know that it occurs at less than 200 CD4 count. So CBC shows normal hemoglobin, no leukocytosis or thrombocytopenia. So essentially CBC is normal. Urinalysis shows mild proteinuria. WBC casts with 5 to 7 red blood cells. What is the most likely diagnosis? So let's eliminate the options one by one. So we have hemolytic uremic syndrome. So what happens in hemolytic uremic syndrome is that they will give, when you have a history of usually it will be a kid, and then they will say that he ate hamburgers, and then there's bloody diarrhea, and then they will say there is like thrombocytopenia and petechial rash. So remember, it's petechial rash, not maculopapular. In this question we have maculopapular rash. Also there is thrombocytopenia. Here there is no thrombocytopenia, so that also rules out hemolytic uremic syndrome. Also there is no bloody diarrhea, no hamburgers. So what happens in hemolytic uremic syndrome is that the endothelium is damaged. So once the endothelium is damaged, the platelets adhere to the endothelium, damaged endothelium, and form microthrombi. Those microthrombi, because it consumes platelets, result in thrombocytopenia, and that thrombocytopenia results in petechial rash. And also, is in addition, if there are red cells, so they will also be shared as they cross these microthrombi and result in these fragmented red cells, or also called helmet cells because of their shape, are schistocytes. So these are fragmented red cells, and also these red blood cells lyse as well. So that results in hemolytic anemia. Here the hemoglobin is normal, so that also rules out hemolytic uremic syndrome. So basically nothing is in favor of hemolytic uremic syndrome except for the fever. So that rules out hemolytic uremic syndrome. Then we have the interstitial nephritis. Remember, it occurs after a drug ingestion. Usually, for example, TMPSMX can cause it. Also cephalosporins, and also for example, some PPIs can also cause it. So here the patient did take the drug that would cause interstitial nephritis. Also there are WBC casts and maculopapular rash and fever. So all of them are in point, and all of them suggest that it is interstitial nephritis. And so remember that with WBC casts are usually eosinophils. Are they eosinophils? So in NBMEs and most of the question banks, they would put eosinophil in interstitial nephritis. And remember the other drugs like cephalosporins and PPI causing the interstitial nephritis as well. And there will be fever and there will be rash. And eosinophil are WBC casts. There can also be like proteinuria, and they can also see some red blood cells or hematuria. So this one is the correct answer here. Then we have the lupus nephritis. So lupus nephritis, remember, usually the rash is just a malar rash, and also it's usually females. Here it's male. The male to female ratio is about, the female to male ratio is about 7 to 13. And so which means that females are 7 times more likely to have lupus. And also usually in lupus you can get like arthralgias, you can get mouth ulcers, and none of which are given here. So lupus, unlikely. And then we have the cholesterol embolism syndrome. Remember, cholesterol embolism is high yield, and so is the interstitial nephritis. So what happens in cholesterol embolism syndrome is that if this is an artery and there is a atherosclerosis going on, for example, patients with MI requiring catheterization. So usually in the history they will give patient who underwent cath like a week back or 2 weeks back and now present with cholesterol embolism syndrome. So when you do catheterization in MI, you actually remove this thrombus, this cholesterol thrombus. This results in all of the cholesterol kind of embolizing, or kind of flowing, the fragments of the cholesterol kind of flowing freely in the systemic circulation, and can go anywhere. It can go to the retina, it can go to the skin, it can cause blue toe syndrome, it can go to the renal and cause acute kidney injury. So it can go anywhere. And you remember, in acute kidney injury there will be WBCs, and those WBCs are also eosinophils. But here they did not give any history of atherosclerosis or catheterization. That rules out cholesterol embolism syndrome. Also, the maculopapular rash is not seen. You may see levator reticularis with it. with cholesterol embolism syndrome. So pyelonephritis is unlikely because they did not give any costovertebral angle tenderness, which is usually present. Also, it's a male, so in males, UTIs are usually not present, really uncommon, and also the rashes would not be expected. So the only thing in favor is just mainly the fever. So that rules out pyelonephritis. So the answer is interstitial nephritis, and remember high yield for the USMLE exam across all the USMLE exams. So a 26-year-old female patient presented with acute onset shortness of breath, palpitations, sweating, and chills. Her sister, who brought her, gives history that the patient has been having these episodes for the past 3 months, but when they come to the emergency department, all the tests, including ECG, are clear. The patient also worries about the occurrence of next episode. Which of the following is the mechanism of action of the drug to immediately relieve this patient's symptoms? So if you look at this is episodic. Like here they say there is episodes, and episodes include shortness of breath, palpitations, sweating, and chills. Remember, the patient still has active symptoms, so they want to know what will be the immediate next step to relieve this patient's current symptoms. So also remember that they said there is increased worry that about the occurrence of next episode. So this is classic for a panic attack. So this is a panic disorder. So usually the panic attacks will occur out of the blue without any reason, and there will be like palpitation, shortness of breath, sweating, chills, paresthesias. Those are the things, and sense of impending doom. So those will be the features of the panic attack. So and remember, episodic. So and then there is also, remember, a type of anxiety called the performance anxiety, and there is also specific phobias as well, like height. So this is different than that. This is just without any reason. For the specific phobias, the reason it's called specific phobia because there is a reason. For example, a patient afraid of heights. So that will be a specific phobia example. So this is definitely panic disorder. For panic disorder, usually you need to know that why the paresthesias happen. Remember, there is also paresthesias. They may ask the question. So remember, the patient hyperventilate, right? There is increased ventilation rate. So when they hyperventilate, they breathe out. They kind of expire PCO2. So if you expire PCO2, there is decreased PCO2. If there is decreased PCO2, that actually causes, if this is a brain, it actually causes the vessels in the brain to constrict, and the vessels in the brain, if are constricted, the area that is supplied by the brain may not have enough blood, and that actually causes the paresthesias. So this is the proposed mechanism for the paresthesias in panic disorder or panic attacks. So let's see what is which drug is going to be used here immediately relieve this patient's symptoms. Remember, now there are active symptoms, so you need to give benzodiazepine. So let's see which of the following would be the mechanism for benzodiazepine. First, they said serotonin reuptake inhibitors. Remember, SSRIs and SNRIs, right? And cognitive behavioral therapy. So these are treatment options for panic disorders. But remember, these are for maintenance, not to relieve the immediate symptoms. Here, we need to immediately relieve this patient's symptoms. So these are not going to be the ideal choice. This is for maintenance. Like, this is to prevent further panic attacks. So here, it's not a right option. Non-selective beta blocker. This would be propanadol. Remember, this is for performance type of anxiety. So if the patient is giving a presentation and is nervous before the presentation, the patient can take propanadol, a non-selective beta blocker. Here, it won't help with the panic attack. Then we have increased frequency of chloride channel opening. So remember, this is the one that is going to be the benzodiazepine. So this one is the right answer. This is the right answer. These two are wrong. So, and then we have the last one, which is the D2 receptor antagonist. These are antipsychotics, so used for schizophrenia, but here they have no value. So just remember, for immediate symptoms, benzodiazepine; for long term, for maintenance, SSRIs, SNRIs, and our cognitive behavioral therapy. So a 28-year-old male patient presented with fever and a rash 3 weeks ago. He returned from a camping trip to Vermont. Examination shows bull's eye rash on the left thigh. temperature is 101, so there is fever, blood pressure is normal, and pulse is normal. There is no history of drug allergies, which means that most likely this rash is not from any drugs. Also, there is no history that any drug was taken recently. So what is the next best step in management? So let's talk about the different options. So first is Lyme serology. So remember, this case looks definitely like a Lyme case, Lyme disease case, because there is fever, there is rash, and also the patient recently went to a Lyme endemic state, Vermont. So remember, New Jersey, New York, Massachusetts. So these are the states that, and also there are others like Wisconsin. You can see the map on Google where there are Lyme disease, because in the vignette they will usually give you those states where Lyme disease is endemic. So here it is Vermont. So also they gave you the classic bullseye rash. So you remember, whenever you see a bullseye rash, right, and there is like fever, rash, also arthralgias, and the patient came from a Lyme endemic region recently, so that is that is definitely Lyme disease. And the thing is, if you don't get this rash, then you would do Lyme serology. But here the case is pretty clear. Like from a scenario, you can see that it is Lyme disease, so we don't need to do Lyme serology. Let's say if they were saying that the same scenario was present and they did not mention anything about the bullseye rash, and they mentioned other features of Lyme disease, like maybe facial palsy or maybe arthralgias, so then we can go with Lyme serology to kind of so that we can confirm the diagnosis. But here the diagnosis is already confirmed from examination. They give you the classic rash, and from the patient came from Lyme endemic region. So then we have the doxycycline therapy. So this would be the answer here. So doxycycline is used for Lyme disease. Remember, Lyme is a systemic infection, so you get a lot of disorders depending on which phase of the Lyme disease the patient is in. So you can get meningitis, you can get carditis, those features the patient can get. And doxycycline has a really good systemic penetration, so that's why this is the first line treatment for Lyme disease. Then with the blood cultures, remember here blood culture will have no role, because the patient is vitally stable. There is just fever, but the patient does not have any hypotension or tachycardia that would suggest SIRS or sepsis. So when you have those like SIRS and sepsis criteria, like pulse greater than 90 and there is hypotension, blood pressure less than 90, systolic blood pressure less than 90, so those will be the criteria for blood cultures. Here it won't have any role. Amoxicillin, remember, is also used for Lyme disease, but one of the things to know is that amoxicillin is used if doxycycline cannot be used. So what are the conditions where doxycycline cannot be used? So doxycycline, avoid in pregnancy. So if they say in the vignette that the patient is pregnant, avoid it, because it can cause fetal bone abnormalities, and it can also cause fetal teeth staining. Also avoid in children less than 7 years, because it can also cause the teeth staining there as well. So avoid in these two scenarios. So in those cases, you can use amoxicillin. Here, doxycycline is the right answer, because the patient is not in the vignette is a 28-year-old male. It's there's no pregnancy in the vignette. There's no the patient is not less than 7 years old. So then we have azithromycin. Azithromycin is not typically used for Lyme disease, so that will also be not the right answer. So remember, whenever you have like a typical scenario, they give you this bullseye rash. Just directly go with and the patient came from Lyme endemic region, directly go with treatment. If they don't give you this, but there is the scenario is still typical, but there is no rash, then go with Lyme serology. Hello everyone, and welcome to another day of high yield Usmle question. So today we'll be talking about GI questions. So a 65-year-old female presented with 2 months history of fatigue and yellow discoloration of the eye. So far it looks like jaundice, and there is also weight loss during this time period, and she also complains of pale stool, so it looks like obstructive. So family history is significant for hypertension and diabetes. This patient, they did not mention that this patient has it. It's just family history. Vitals are normal. Patient on examination shows there is severe icterus, and labs are following. So total bilirubin is really high and direct is high, so it means the direct hyperbilirubinemia. So ALP is also through the roof, so it's really high. AST and ALT are normal. Antimitochondrial antibodies are negative, and what is the likely cause of this patient's symptoms? First is the Wilson disease, and the Wilson disease would be wrong. First, because this is a 65-year-old female. Usually, Wilson will be younger, like 17-year-old, 18-year-old, less than 30, usually less than 30 or 35. So Wilson will be wrong here. Also, there will be usually neurologic symptoms they give for Wilson. There are also KF rings, case of Fleischer rings they give on the slit lamp examination, increased urinary copper and decreased serum ceruloplasmin. So those are the features. But here, the patient is really old, and I don't think, and the picture is obstructive jaundice. So also AST-ALT are normal. So Wilson usually affects the AST-ALT as well. So those would be the reasons that Wilson is wrong. And Wilson is genetic, right? So that's why younger patients are affected most. Then acute hepatitis is also wrong, and you can easily exclude this acute hepatitis by looking at the AST and ALT. These are normal. So remember, in acute hepatitis, they are through the roof. They are like greater than 1,000 AST and ALT. You should know, like, if ALT and AST are greater than 1,000, think about three things. On NVMEs or on USMLE. It could be acute viral hepatitis, like hepatitis A, B, C, D. Even herpes and CMV can cause acute viral hepatitis. So think about acute viral hepatitis. Second, acute ingestion of paracetamol. So that would be the second. The third is shock liver. And shock liver is just ischemia. For example, there is heart failure, there is hypovolemia, hemorrhagic shock. So that results in decreased flow to the liver and damages the liver. So here, AST-ALT normal, acute hepatitis rules out. And hemochromatosis, again, usually will affect the AST-ALT levels here. ALT-AST levels are not affected. Hemochromatosis, remember, on boards, a few high yield points are that Vibrio vulnificus infection is increased. Vibrio vulnificus, usually oyster or shellfish, those things are eaten by the patients, and then they present with hemorrhagic bouillon skin. So that's Vibrio vulnificus. Vibrio vulnificus would be associated with hemochromatosis. So and the reason for Vibrio vulnificus is that it is iron loving. So, and hemochromatosis, you get a ton of iron. So here, AST-ALT normal, so most likely hemochromatosis will not be the right choice here. Also, hemochromatosis has other features like joint pain. Those are not seen here. Malignancy. Yeah, so this one, malignancy looks like this could be it, right? There is weight loss, features suggestive of malignancy, yellow discoloration, weight loss, pale stool, could be a mass obstructing the biliary tracts. So here, ALT is raised, which most likely means that it is some sort of looks like it is mainly affecting the biliary tracts. Could be cholangiocarcinoma. So it could be any malignancy, remember. And primary biliary cholangitis is not the right answer, because they said here is that the antimitochondrial is negative. And remember, this affects intrahepatic channels, biliary ducts, intrahepatic biliary ducts. So if you have the intrahepatic, and you can remember this by females. It also affects females mostly. So females are usually like indoors, and so that's where you can just kind of remember that primary biliary cholangitis affects intrahepatic ducts. And so then let's talk about this malignancy. What could have caused that malignancy? So it could be any. So if this is if this is the liver, and this is the biliary tract, and you also have the pancreas here. Pancreas is here. And the biliary tract comes here and then empties in the duodenum. Remember, to the liver, a lot of like the pancreatic cancer can here cause obstruction and present with this feature. The GI, for example, if this is a GI tract, ascending, descending colon, remember the most common site of metastasis for colon cancer is the liver. And if they ask you why, because all of the blood that is draining the colon is through the portal vein, and the portal vein goes to the liver. So the malignant cells, when they get injury to the blood, the first organ they encounter is the liver, because it is drained through the portal vein into the liver. So this is the first organ encounter. So liver metastasis is the number one site of metastasis for colon cancer. So here, The obstructive jaundice can also be caused by this pancreatic cancer as well. So it could be any cancer. It can also be like the cholangio, like I said, because AST really elevated. So it could be cholangiocarcinoma. Remember, one of the risk factors for cholangiocarcinoma is primary sclerosing cholangitis, which is associated with ulcerative colitis. And also, primary sclerosing cholangitis is also associated with colon cancer. So these are all high yield for Usmle, and you should absolutely know this. And if anyone requires tutoring, so you can email me here, and please like and subscribe to this channel if it helps you. Hello everyone, welcome to another day of Usmle, high yield Usmle questions. Today we are going to be talking about endocrinology. So we have a 45-year-old male present to the hospital with muscle weakness. The patient's BMI is 32, so the patient's obese. Vitally blood pressure is 150/90, so blood pressure is elevated, pulse is 70, which is okay, and temperature is okay. On examination, the patient has an obese abdomen with abdominal striae. So, and there is proximal muscle weakness. Late night salivary cortisol is elevated, so that's Cushing's. ACTH is also elevated, so then we have to know that it is ACTH dependent Cushing's. Low dose dexamethasone suppression test did not lower the ACTH level, so that confirms that it is Cushing's. While high dose dexamethasone did lower the ACTH levels. So, which of the following will likely be seen in this patient? So this is definitely a really typical scenario of Cushing's. They can give you a lot of features of Cushing's in the question stem. They can say hirsutism, they can say abdominal striae, hypertension, they can say insulin resistance, high glucose levels, so hyperglycemia. They can give you a lot of those things. So here I've put some of the features that they can give, like muscle weakness. So let's talk then what they're asking. So a few things you should know. First, let's talk about them. So first is that if this is the let's say the pituitary, right? The pituitary releases ACTH, and then if we have the adrenals here, the adrenals which are on top of the kidneys, so the ACTH will come here and it will cause the adrenal gland to release cortisol. So now, a few things to keep in mind. If the Cushing's is because of an adenoma here in the adrenals, then adrenals produce in the pituitary. If there is an adenoma in the pituitary adenoma that is secreting the ACTH, then that one is called Cushing's disease. It has a separate name. The other ones are called Cushing syndrome, and so. If this is producing ACTH, let's say, and then there is also some other, because this patient has elevated his ACTH, so now we have to know what caused the ACTH elevation. So one thing is this, Cushing disease, the pituitary adenoma. Another thing is ectopic ACTH. Ectopic, usually that's cancer, usually of the lungs, lung cancer. So this here is going to produce excess ACTH. So now, how are you going to differentiate that this ACTH is coming from the pituitary or is it coming from the lung cancer? So for that, you do the high-dose dexamethasone suppression test. Remember, a low-dose dexamethasone suppression test is just the initial test. That kind of confirms that it is Cushing's, but it does not tell you if it is Cushing syndrome or if it is Cushing disease. So if the high-dose dexamethasone suppression test, if it suppresses ACTH, that means that it is a Cushing disease, that is the pituitary. If it did not suppress, so that will be this. If it did not suppress ACTH, the high dose dexamethasone suppression test, then it is the ectopic ACTH. Here it did suppress, right? So that is pituitary. So most likely the patient is suffering from this Cushing disease, pituitary adenoma. So now another thing to be aware of, so when you have ACTH due to any reason, elevated ACTH, it will kind of stimulate this pituitary. It will just stimulate it so much that it will undergo hyperplasia, and both of the adrenals will undergo hyperplasia. So ACTH elevation due to any reason, it could be lung cancer, it could be the pituitary adenoma. So it will cause bilateral hyperplasia of these glands. So now let's talk about the options. So bilateral adrenal atrophy, that is a wrong answer, and the reason for this is because this is going to be seen in exogenous steroids. So now let's say someone is let's say this is your adrenals, and let's say exogenous, right, which is the most common cause of Cushing's. If someone is taking exogenous steroids, let's say exogenous steroids are used, and they are gonna go to your pituitary and suppress ACTH ACTH decrease. There is no action of ACTH on the adrenals. The adrenal eventually will undergo atrophy. So there will be bilateral atrophy of the adrenals, because steroids, exogenous steroids, suppress ACTH. That results in this. So this is definitely not exogenous, right? Because ACTH is elevated, it is not suppressed. So that rules it out. Then bilateral adrenal aplasia, as we discussed, this is the right option. Then adrenal adenoma. Adrenal adenoma, again, if let's say we have the adrenal here, and the adrenal is has this tumor, and it is producing cortisol. Again, this cortisol is going to go to the pituitary and suppress ACTH. So that's actually going to present with low ACTH. Then another option is adrenal carcinoma. Again, the same. If there is a carcinoma here that is producing cortisol, the cortisol is going to go and suppress ACTH. So ACTH should be low. In the question, it is high. So then unilateral adrenal atrophy. So this is interesting. So this is going to be seen, for example, if you have one adrenal here, and let's say this one has the tumor, right? And the tumor producing cortisol. Cortisol is going to the pituitary, and decreasing ACTH. So this adrenal adenoma going to the pituitary is decreasing ACTH. There is no ACTH here, so it will not act on this pituitary, and this is going to undergo, the unaffected one is going to undergo atrophy. The one with the adrenal adenoma is going to continue secreting cortisol. That is going to suppress ACTH. There is low ACTH, so the other unaffected with the adrenal without the adenoma will undergo atrophy. So hope this question was helpful, and if it did help you, please like and subscribe. And if anyone wants tutoring, you can email me here. Hello everyone, and welcome to another day of high yield Usmle questions. Today we'll be talking about endocrinology. So a 45-year-old male with CKD comes to the office for follow-up. He's not on dialysis. Vitals are normal, labs are following. So we have the creatinine, for obvious reasons, is high because the patient is CKD. BUN is high and serum calcium is high. Remember, if it's greater than 10.2, that is high. And phosphate is normal, up to 4.5 is normal. And PDH is really high. I think about 60 is the upper limit of normal, so this is really high. So now they're asking about what could be the reason for this hypercalcemia. So what caused this hypercalcemia? So let's go through each of the options. So now we're talking about malignancy. So they are talking about hypercalcemia of malignancy. Hypercalcemia of malignancy. So here usually that's PT HRP, parathyroid hormone related peptide, and usually, for example, small cell cancer, this will be associated with. But remember, the problem here is that even though the PTHRP would be elevated, that will lead to increased calcium, really increase like 14 or greater than 14. But the thing is, this calcium will in turn go to the gland, parathyroid gland, and it will suppress PTH. So the PTH will be low. Here it's really high, so that rules it out. Then parathyroid adenoma. So let's talk about parathyroid adenoma. PTH is high. Parathyroid adenoma is primary hyperparathyroidism. So if it's an adenoma here, so it makes sense. Yes, PTH can be high here. Second, calcium can be elevated. Yes, it can be elevated. Can phosphate be normal? Phosphate can be normal. So we're going to keep this for now. Then we have CKD. So in CKD, the patient is having CKD, but here they said the calcium is high. Remember, in CKD there is hypocalcemia, and that leads to increased PTH. But here we are having hypercalcemia, so that will rule it out. And in CKD, remember, the reason for hypocalcemia, right? Because CKD is involved in vitamin D synthesis, and vitamin D is not there. So that's usually the reason and there will also be hyperphosphatemia. This patient's phosphate is normal, and PTH, even though that will be elevated. But remember, there is a end-stage renal disease, where these patients are usually on dialysis, where the gland becomes autonomous. This parathyroid gland becomes autonomous, and the reason for and by that I mean is that it increases PTH levels. The PTH level really high, regardless of serum calcium levels. So the calcium may be elevated, may be low. It doesn't matter. The PTH is still kind of crazy high. It's just still going to. This is the reason it is called autonomous. Here, that's not be the case, because the patient's CKD is it doesn't look like it's end stage now, because the patient is not on dialysis. Usually these patients are on dialysis. If this patient had, then this would have been the right answer. But the patient is not on dialysis. It doesn't look like the patient having end stage renal disease. So this is not the case here. Then immobilization, will cause hypercalcemia, but the thing is the PTH will be low. Osteoporosis, remember, all the labs are normal in osteoporosis. So important thing to be aware of. So hope this video was helpful, and if it helped, please like and subscribe to the channel, and if you require tutoring, you can email me here. Thank you. Hello everyone, and welcome to another day of high yield Usmle questions with me. Today we will be talking about renal, so let's talk about it. A 25-year-old male presented with prior history of HIV, presented with maculopapular rash and fever. A few weeks ago, he was treated with pneumocystis pneumonia with TMPSMX. So pneumocystis pneumonia is common in HIV, and you should know that it occurs at less than 200 CD4 count. So CBC shows normal hemoglobin, no leukocytosis or thrombocytopenia, so essentially CBC is normal. Urinalysis shows mild proteinuria, WBC casts with 5 to 7 red blood cells. What is the most likely diagnosis? So let's eliminate the options one by one. So we have hemolytic uremic syndrome. So what happens in hemolytic uremic syndrome is that they will give, when you have a history of usually it will be a kid, and then they will say that he ate hamburgers, and then there is bloody diarrhea, and then they will say there is like thrombocytopenia and petechial rash. So remember, it's petechial rash, not maculopapular. In this question we have maculopapular rash. Also there is thrombocytopenia. Here there is no thrombocytopenia, so that also rules out hemolytic uremic syndrome. Also there is no bloody diarrhea, no hamburgers. So what happens in hemolytic uremic syndrome is that the endothelium is damaged. So once the endothelium is damaged, the platelets adhere to the endothelium, damaged endothelium, and form microthrombi. Those microthrombi, because it consumes platelets, result in thrombocytopenia, and that thrombocytopenia results in petechial rash. And also, in addition, if there are red cells, so they will also be sheared as they cross these microthrombi and result in these fragmented red cells, or also called helmet cells, because of their shape, are schistocytes. So these are fragmented red cells, and also these red blood cells lyse as well. So that results in hemolytic anemia. Here the hemoglobin is normal, so that also rules out hemolytic uremic syndrome. So basically nothing is in favor of hemolytic uremic syndrome except for the fever. So that rules out hemolytic uremic syndrome. Then we have the interstitial nephritis. Remember, it occurs after a drug ingestion. Usually, for example, TMPSMX can cause it. Also cephalosporins, and also for example, some PPIs can also cause it. So here the patient did take the drug that would cause interstitial nephritis. Also there are WBC casts and maculopapular rash and fever. So all of them are in point, and all of them suggest that it is interstitial nephritis. And so remember that with WBC casts are usually eosinophils. Are they eosinophils? So in NBMEs and most of the question banks, they would put eosinophil in interstitial nephritis. And remember the other drugs like cephalosporins and PPI causing the interstitial nephritis as well. And there will be fever and there will be rash. And eosinophil are WBC casts. There can also be like proteinuria, and they can also see some red blood cells or hematuria. So this one is the correct answer here. Then we have the lupus nephritis. So lupus nephritis, remember, usually the rash is just a malar rash, and also it's usually females. Here it's male. The male to female ratio is about 7 to 13, and so which means that females are 7 times more likely to have lupus. And also usually in lupus you can get like arthralgias, you can get mouth ulcers, and none of which are given here. So lupus unlikely. And then we have the cholesterol embolism syndrome. Remember, cholesterol embolism is high yield, and so is interstitial nephritis. So what happens in cholesterol embolism syndrome is that if this is an artery and there is a atherosclerosis going on, for example, patients with MI requiring catheterization. So usually in the history they will give patient who underwent cath like a week back or 2 weeks back and now present with cholesterol embolism syndrome. So when you do catheterization in MI, you actually remove this this thrombus, this cholesterol thrombus. This results in all of the cholesterol kind of embolizing, or kind of flowing, the fragments of the cholesterol kind of flowing freely in the systemic circulation, and can go anywhere. It can go to the retina, it can go to the skin, it can cause blue toe syndrome, it can go to the renal and cause acute kidney injury. So it can go anywhere. And you remember, in acute kidney injury there will be WBCs, and those WBCs are also eosinophils. But here they did not give any history of atherosclerosis or catheterization. That rules out cholesterol embolism syndrome. Also, the maculopapular rash is not seen. You may see levator reticularis with it. With cholesterol embolism syndrome. So pyelonephritis is unlikely because they did not give any costovertebral angle tenderness, which is usually present. Also, it's a male, so in males UTIs are usually not present, really uncommon, and also the rashes would not be expected. So the only thing in favor is just mainly the fever. So that rules out pyelonephritis. So the answer is interstitial nephritis, and remember, high yield for the USMLE exam across all the USMLE exams. So I hope this video was helpful. If any student require tutoring, he can email me here, and consider supporting the channel here, a link in the description. Hello everyone, and welcome to another day of high yield USMLE questions. So today we will be talking about psychiatry. So a 26-year-old female patient presented with acute onset shortness of breath, palpitations, sweating, and chills. Her sister who brought her gives history that the patient has been having these episodes for the past 3 months, but when they come to the emergency department, all the tests including ECG are clear. The patient also worries about the occurrence of next episode. Which of the following is the mechanism of action of the drug to immediately relieve this patient's symptoms? So if you look at this is episodic. Like here they say there is episodes, and episodes include shortness of breath, palpitations, sweating, and chills. Remember, the patient still has active symptoms, so they want to know what will be the immediate next step to relieve this patient's current symptoms. So also remember that they said there is increased worry about the occurrence of next episode. So this is classic for a panic attack. So this is a panic disorder. So usually the panic attacks will occur out of the blue without any reason, and there will be like palpitation, shortness of breath, sweating, chills, paresthesias. Those are the things, and sense of impending doom. So those will be the features of the panic attack. So and remember, episodic. So and then there is also, remember, a type of anxiety called the performance anxiety, and there is also specific phobias as well, like height. So this is different than that. This is just without any reason. For the specific phobias, the reason is called specific phobia because there is a reason. For example, a patient afraid of heights. So that will be a specific phobia example. So this is definitely panic disorder. For panic disorder, usually you need to know that why the paresthesias happen. Remember, there is also paresthesias. They may ask the question. So remember, the patient hyperventilate, right? There is increased ventilation rate. So when they hyperventilate, they breathe out. They kind of expire PCO2. So if you expire PCO2, there is decreased PCO2. If there is decreased PCO2, that actually causes, if this is a brain, it actually causes the vessels in the brain to constrict, and the vessels in the brain, if are constricted, the area that is supplied by the brain may not have enough blood, and that actually causes the paresthesias. So this is the proposed mechanism for the paresthesias in panic disorder or panic attacks. So let's see what is which drug is going to be used here. Immediately relieve this patient's symptoms. Remember, now there are active symptoms, so you need to give benzodiazepine. So let's see which which of the following would be the mechanism for benzodiazepine. First, they said serotonin reuptake inhibitors. Remember, SSRIs and SNRIs, right? And cognitive behavioral therapy. So these are treatment options for panic disorders. But remember, these are for maintenance, not to relieve the immediate symptoms. Here, we need to immediately relieve this patient's symptoms. So these are not going to be the ideal choice. This is for maintenance. Like, this is to prevent further panic attacks. So here, it's not a right option. Non-selective beta blocker, this would be propanol. Remember, this is for performance type of anxiety. So if the patient is giving a presentation and is nervous before the presentation, the patient can take propanol, a non-selective beta blocker. Here, it won't help with the panic attack. Then we have increased frequency of chloride channel opening. So remember, this is the one that is going to be the benzodiazepine. So this one is the right answer. This is the right answer. These two are wrong. So, and then we have the last one, which is the D2 receptor antagonist. These are antipsychotics, so used for schizophrenia, but here they have no value. So just remember, for immediate symptoms, benzodiazepine; for long-term, for maintenance, SSRIs, SNRIs, and our cognitive behavioral therapy. So if you like the video, please subscribe and like the channel. And if anyone wants tutoring, can email me here. And also, if this video helps you in your preparation, you can consider supporting the channel at Buy Me a Coffee, link in the description. Thank you for watching. Hello everyone, and welcome to another day of high yield Usmle questions. Today we will be talking about hematology and oncology. So we had a 19-year-old girl presented with red spots over her entire body. She has no history of any medical condition. On examination, there are petechiae and ecchymosis, as shown in the image. PT and APTT are normal. Platelets are 10,000 with normal WBC and RBC and hemoglobin. Which of the following is the most likely diagnosis? So here you can see this was a real patient of mine, and here you can see a lot of ecchymosis here. There are petechiae. One is here, one is here. Also, if you look at distally here in the on the leg, there are a lot of petechiae. So or the entire body, there are petechiae, and so PT and PTT are normal and platelets are low. So what could be the diagnosis? So first, let's talk about the Waldenrein. Remember, Waldenrein can cause petechiae and cutaneous bleeding, but here APTT may be normal, but it may also be elevated because factor 8 normally Waldenrein stabilizes. But remember, platelets will be normal in Waldenrein disease. So this is a wrong answer here. ITP is the right answer because here the only abnormality is the low platelets. So most likely this patient has ITP, where you get only the platelets defect, where the not defect, but it's just the numbers are low. So platelets number are low. There is no qualitative defects. It's a quantitative defect where platelets are reduced because of destruction. So DIC, PT, PTT will be elevated. So this is will be elevated. So here they are normal, PT, PTT. So that's not the diagnosis. Empty fatty marrow, they're referring to aplastic anemia. This is also a wrong answer because in the question they said that the WBC and RBC are normal. Here you get pancytopenia, where RBC, WBC, platelets, all of them are low in aplastic anemia, and so. Here, this is definitely immune thrombocytopenic purpura. And so what happens there is that if this is the spleen actually produces antibodies, and this is, let's say, the platelet, and against the platelet GP2B3A receptor. That's where the antibodies are directed against. So the spleen produces them, remember, and then those antibody-bound platelets come back to the spleen, and the spleen kind of eats them. The splenic macrophages. So the main problem is with the spleen. So then, how do you kind of treat ITP? So ITP, remember, if the platelet count is greater than 30,000 and there are only cutaneous symptoms, like in this patient, there are cutaneous symptoms, and but platelet count is less than 10,000. So, but if it is greater than 10,000 and there are only cutaneous symptoms, you observe. If it is less than equal to less than 30,000 platelet count, and there is bleeding or cutaneous symptoms, then you treat. So this patient should be treated because the platelet count is less than 30,000. So what is the treatment? The treatment is glucocorticoids. So first is glucocorticoids, and if glucocorticoids doesn't work, then you can use IVIG, and if that doesn't work, rituximab, and then eventually, if it is very refractory, then splenectomy, because we talked, the splenectomy, spleen is the problem here. Splenectomy will actually you're kind of killing two birds with one stone, because you're actually decreasing the production of those antibodies which are produced by the spleen. Also, you're removing the source of destruction of the platelets, and so that's important. Also, remember associations. Immune thrombocytopenia is associated with HCV, HIV, also with SLE. So all of these conditions should be ruled out because it's a diagnosis of exclusion. And if they say spleen should be curative, right? Splenectomy should be curative. But if they say the patient removed the spleen and now 6 months later the patient comes back with the same symptoms of ITP, so you suspect accessory spleen. So you can do CT MRI to look for accessory spleen in that condition. So I hope this was clear, and if you like the content, you can help support the channel here, link in the description. Also, if anyone requires tutoring, can email me here. So thank you for watching. Hello everyone, and welcome to another day of high yield Usmle questions. Today we will be talking about OBGYN. So we have a 28-year-old female present to the office with continuous leakage of clear watery fluid from the vagina. A few months ago, she underwent pelvic irradiation for an ovarian malignancy. There is no fever or bleeding from the vagina. Vagina examination showed pooling of fluid in the vagina. And what is the next best step in management? So let's go over that. So a lot of here, there is a risk factor, pelvic irradiation for vesicovaginal fistula. So this is definitely vesicovaginal fistula, where you have like day and night. The patient is going to present with vaginal discharge, clear vaginal discharge, day and night, and that discharge, the watery discharge, is actually just watery fluid is just urine. And so they may give you red granulation as well on the vaginal wall, so look out for that as well. And also the pooling of fluid in the vagina, that is really high yield, pooling of the vagina, and then red granulation as well. And this risk factor, pelvic irradiation. Remember, the most common risk factor for vesicovaginal fistula is obstructed labor. But here it's the pelvic irradiation, prolonged labor, obstructed labor. These are other risk factors. So now let's go over like what do you do for vesicovaginal fistula. So here the first is they say a NAT test for chlamydia and gonorrhea. Remember, chlamydia and gonorrhea will cause mucopurulent discharge. Also, they wouldn't cause this pooling of fluid. So this would be the wrong answer. Then wet mount microscopy is for bacterial vaginosis, and here you do get like a watery discharge, but it's not gonna be like this much. It's not gonna say that there is pooling. There will be no pooling here. So this is the wrong answer. So also they can say odor, like odor discharge. It has like a foul odor, but remember, so does the vesicovaginal fistula can have a odor, like foul smelling fluid, could be foul smelling fluid, because it is urine. And so remember, the wet mount microscopy, you usually wouldn't see this pooling of fluid. You will never see this pooling of fluid. And so then we have the urine culture. The urine culture is for UTIs. This patient does not have any dysuria or anything. Dysuria, or there is no fever. If you're suspecting some sort of, for example, pyelonephritis, because this status usually doesn't have fever. Then so that's the wrong answer. Then with the dye test, the bladder dye test is actually the right answer. And so let's explain that. So if we have this bladder, let's say we have this bladder, then posterior to the bladder we have the vagina here, and so a fistula forms here due to any reason, obstructed labor, the pelvic irradiation. And so then what you do is that you put a tampon here, and let's say this patient here has a lot of fluid, the urine, and the urine can go there. But now let's inject some dye into this. So like I said, this blue thing is a dye. So you put a tampon and then you put a dye there, and the dye will come here and stain this this tampon. And when you take out the tampon, and if you see this staining of that tampon, that means that it is that would be a vesicovaginal fistula. But if the defect is small, then you can actually scope it. You can actually scope the bladder. You can do cystoscopy to visualize small small defect which cannot be detected by bladder dye test. So that would be the right answer here. This is the right answer. And then CT scan is the wrong answer. Usually you wouldn't see the fistulas with the CT scan. So hope this video was helpful, and if any of this helps you, you can support the channel here. Also, you can get you can buy my notes, the triads, where all the clinical triads that they show up on the USMLEs. I made just 1-page document of that. So if you want to buy that, it will be available here. And if anyone requires tutoring, they can email me here. Thank you for watching. Hello everyone, and welcome to another day of high yield USMLE questions. Today we will be talking about neurology. So your 18-month-old boy is brought to the office by his mother due to bruise around the eye. That started a week ago. Mother is also complaining that the boy has lost weight and is irritable. Widely, the patient is stable. On examination, there is right-sided abdominal mass. The patient also has drooping of the right eyelid and miosis. The tumor this patient has can also be found in which of the following locations? So this is a case of neuroblastoma, and one of the things that the USMLE wants you to differentiate it from is Wilms tumor. The classic one that students remember is that Wilms tumor does not cross the midline, and neuroblastoma crosses the midline. Also, there are some other features of neuroblastoma that also helps differentiate neuroblastoma from Wilms tumor, which include is the dancing eye syndrome, which is also called opsoclonus myoclonus syndrome. And so here I did not give any of those classic features. I did not say that the mass crosses the midline, so that would most people would think that it is Wilms tumor. I also did not mention opsoclonus myoclonus syndrome. Also, as I did not say that the tumor crosses the midline, but it's still neuroblastoma case, because here you have 2 clues to the neuroblastoma. First is the Horner's syndrome. Also, the Horner's syndrome here, I did not give sweating because often in children it's really difficult to know the anhydrosis, because in Horner syndrome you see ptosis, meiosis, and anhydrosis. Here I just gave you the ptosis and the meiosis. So that's one clue. Another clue is the bruise around the eye. So that is also called raccoon eyes, which is because of the orbital metastasis. You can see that in neuroblastoma. So those are the main features of neuroblastoma. So that's why this helps differentiate it from Wilms tumor. Wilms tumor will not have those features. So now, remember, there are a few locations where you can see the neuroblastoma. One of the locations is the posterior mediastinum. This is the right answer. You can also see it most commonly in adrenal glands. About 35% are in the adrenal glands, and around about 20% are in the posterior mediastinum. So most people will be thinking about the kidneys, but the kidney is the wrong answer. That will be for Wilms tumor, and the Wilms tumor is the wrong answer here because there are Horner syndrome features, and there is also periorbital ecchymosis going on. So that is the neuroblastoma. So in neuroblastoma you can get elevated catecholamine levels. Catecholamine levels can be elevated. You can have weight loss, like here. The patient can be irritable as well. In real tumors, that's usually associated with things like the Vagar syndrome, where there's Vagar syndrome is there, and there's also Beckwith-Wiedemann syndrome. There is muscle hemihypertrophy and those features going on. So hope this video was helpful, and if anyone wants tutoring, they can email me here. If anyone wants to support the channel, they can support the channel here. So hope this video was helpful, and see you in the next one. Hello everyone, and welcome to another day of high yield USMLE questions. Today we'll be talking about neurology. So we have a 31-year-old male patient presented to the emergency department after hitting the head or the side of his head caused by a fall. He lost consciousness after that, but regained consciousness 10 to 15 minutes before losing consciousness again. Widely, the patient is stable. The patient also has had episodes of vomiting. Which of the following is the most likely diagnosis? So let's talk about this. So remember when they say the side of the head? So usually, if this is the side of the head, especially in the pterion area, is the weakest on the side of the bone. This is where the parietal, the frontal, the parietal, the sphenoid, and the temporal bones. So these kind of combine. This is called the pterion area. So it's really the weakest area. And so if the patient gets hit here, there's a trauma here. Right underneath it is an artery. Let's say if this is the artery, and let's say this is the dura. So this is the dura, and this is the arachnoid matter, and then we have this is the pia mater, and then under the pia mater, this is the brain. So what happens here is that once the pterion gets hit, this artery, which is called the middle meningeal artery, underneath it, it's gonna cause accumulation of this blood. And this is called epidural hematoma because it's just outside the dura, so that's why it's called epidural. And remember, it does not cross the suture lines. So this one is epidural. It is classically there is a lucid interval associated with this, and lucid interval is just for example, the patient gets hit, loses consciousness, and then again there is improvement or lucid interval where the blood kind of start to accumulate, and that's usually lasts short amount of time, and this time where the patient kind of gains consciousness is called the lucid interval, and then it is followed by further deterioration of the patient's condition, like here loses consciousness 10 to 15 minutes after that, after the slight improvement. So that is the lucid interval, and it's classically in epidural hematoma. So remember, this is a convex shape. By convex shape, you will see a white kind of hemorrhage on a CT scan, non-contrast CT. So this will be the epidural. Remember the lucid interval, and remember the side of the head, and remember the middle meningeal artery is involved. But if you look at another hemorrhage that you need to kind of differentiate it from, and that would be let's say again, this is the dura, this is the arachnoid, and this is the pia, and then we have here is the brain. And so what happens here is that we also have some bridging veins. So if this is the subarachnoid, the bridging vein kind of come like this. This one is the skull, and so these bridging veins, when they kind of shear, they can also cause, for example, from a fall. They can also cause it can also result in. So when these veins are kind of sheared, it can cause subarachnoid, like this is the subarachnoid space hemorrhage. And remember, this on a CT, because it can cross the suture lines, it appears like this. It appears like a crescent shape. So this is biconvex, this is crescent. And remember, there is no lucid interval here. So, and usually subdural you would see in usually you will see it in old individuals, and it can be acute or chronic. Acute can result in loss of consciousness. Chronic can result in confusion and memory loss in old individuals. And the reason is because it kind of shrinks, and what's in the brain shrinks in old age. It can actually stretch these veins, these bridging veins, and this stretch can cause rupture because they're weak. They have weak walls. And so here, this is how, as we discussed, usually older individuals. It can also cause from fall, for also alcoholics, or anything that causes brain atrophy. So here, no, this is 31-year-old, and there is a fall, and there's also a classic lucid interval that is seen in epidural hematoma. So epidural hematoma would be the correct answer. Subarachnoid, no, usually subarachnoid, it can be ADPKD, autosomal polycystic kidney disease, where there are like aneurysms, and it can cause kind of rupture. So it can cause hypertensive patients. It can be seen, but the lucid interval is not characteristic. Intraventricular hemorrhage, usually just remember for children or infants or premature infants in the ventricular region. So if this is the ventricle, there are some vessels in the a germinal matrix, and those vessels kind of are really friable. So in a preterm infant, these can rupture and cause intraventricular hemorrhage, and the really poor prognosis if intraventricular hemorrhage occurs, and also vitamin K deficiency, because these patients are increased risk of hemorrhage. So hope this video was clear and helpful, and if this helps, you can help supporting the channel here, link in the description. Also, if anyone requires tutoring, can email me here. Thank you for watching. Hello everyone, and welcome to another day of I Yield Usmle questions. Today we will be talking about rheumatology. So we have a 35-year-old male patient present to the emergency department with severe pain in the left great toe. His BMI is 32. He has end-stage renal disease for which he receives hemodialysis. On examination, the left toe is warm, erythematous with severe tenderness. What is used for this patient's management? So as you can see, this is a really typical scenario of gout. So gout is monosodium urate crystals that deposit in the joints. Most commonly it will be the toe. It will be the great toe. And so here is the gout flare. And so there are three things that you should keep in mind that are used for gout flare. So first, NSAIDs can be given. Then we can give steroids. And the third is colchicine. So remember, colchicine is for recurrent or prophylaxis for recurrent gout attacks. And NSAIDs and steroids are usually first line. So NSAIDs, if you have a renal injury, for example, this patient has, NSAIDs would be contraindicated. So here you cannot give NSAIDs because the patient has end-stage renal disease. So that would rule out NSAIDs because they will kind of decrease the prostaglandins and further decrease the blood flow towards the kidney, and so that is not going to be given. And so the second best step here is the steroids, intra-articular steroids. So this will kind of reduce that inflammation in the joint. So if this is a joint, and there's a lot of inflammation that is going on here because of the MSU, monosodium urate crystals, and so that inflammation will be settled by the intra-articular steroids. Then we have allopurinol and febuxostate. So remember, these are xanthine oxidase inhibitors, and they may be used for prolonged therapy to prevent recurrent gout attacks, but they cannot be used during an active flare of gout. And so these are only for for prolonged management. They can also be used, for example, in tumor lysis syndrome. Also, like before chemo, you can use it as a prophylaxis. So with IV fluids, so you can give fluids, you can give febuxostate or allopurinol, and there's another one called resburicase. Those can be used. And so let's touch a little on the biochemistry. So we have a purine metabolism. So we have the purines that are kind of broken down into hypoxanthines. And remember, pure is gold, is the mnemonic. Pure is gold. So the purines include adenine, and guanine. And so it is broken down into hypoxanthine. Then the hypoxanthine is kind of broken down into xanthine, and the xanthine is converted into uric acid, and then that uric acid is converted into allantoin, and this is kind of excreted in the urine. And so now, first, let's talk about the steps. Here is xanthine oxidase involved. Here is xanthine oxidase involved, and here we have urate oxidase. And so remember, so these two, febuxostat and allopurinol, they will kind of block this step, and so then you don't form the uric acid, and so the uric acid is not going to be available to be deposited in the joint to cause inflammation in gout. And so that is ruled out because because this is kind of, they're used for chronic management, not during acute attack. So then we have something called here, another thing called the resburicase, and here you are going to inhibit this urate oxidase. They inhibit the uric oxidase, and that is going to convert uric acid into a more soluble form, which is excreted in the urine. So So this is something about the pathway of the uric acid metabolism and the purine catabolism. And so resbirocase, allopurinol, febuxostat, usually, and IV fluids, they're usually given before chemo to patients with lymphomas to prevent tumor lysis syndrome, and they can also be used for the treatment of tumor lysis syndrome. So hope this video was helpful, and if this video is helpful, you can help support the channel here, link in the description. And also, if someone requires tutoring, you can email me here. Thank you for watching. Hello everyone, and welcome to another day of high yield Usmle questions. So today we will be talking about pulmonology. So a 50-year-old male patient presented with confusion 2 weeks back. He did a chest x-ray which showed a mass. The patient did not come for follow-up after the x-ray finding. He has 20 pack years smoking history. While waiting for the lab results, the patient developed seizures. Lab shows serum sodium of 115, so that's really severe hyponatremia, severe symptomatic hyponatremia, and potassium of 4 and chloride of 100. So potassium and chloride are normal. Which of the following will be seen in this patient due to his condition? So this patient definitely has some sort of lung cancer, because he has a mass here. Also, now the patient also has hyponatremia. So the main thing here to know is that most probably this patient is having SIADH secondary to a lung cancer, and the most common lung cancer that would cause SIADH or perineoplastic syndromes would be small cell lung cancer. So remember, whenever you have perineoplastic syndrome, think about small cell lung cancer. With the lung cancer, there is a perineoplastic syndrome like SIADH. Also, but like all of other perineoplastic syndromes include ectopic ACTH production, which can cause Cushing's. So and also like PTHRP is another ectopic production of a hormone that is also perineoplastic syndrome. But remember, the PTHRP, thyroid related peptide, would be associated with squamous cell carcinoma and not small cell carcinoma. So if you see hypercalcemia with a lung mass and smoking history, think about squamous cell carcinoma that releases this PTHRP, parathyroid hormone related peptide. So let's explain this this question. So now we know it is small cell carcinoma because it is SIADH because of the hyponatremia. So now SIADH, what happens in SIADH is that there is increased production of the ADH hormone. So what does ADH do? So if this is a nephron, and let's say this is a artery, so in the nephron we have water, we also have solute. So let's just represent that by sodium because that's a major solute. So what ADH does is that it reabsorbs this water. And remember, it's free water that it reabsorbs, just the water, not the sodium. So, and here we have a sodium as well. So if you increase the absorption of free water, you are going to dilute this sodium in the blood, and so that leads to hyponatremia. Also, the urine will be concentrated because now you're just kind of getting all of the blood out, and so it is getting concentrated, the sodium levels. So here, that's why this patient is having hyponatremia, because of the free water reabsorption, because of there is a ton of ADH in the body. And so then what would be finding here? So now if there is increased H2O reabsorption, you would expect a really hypervolemic state where you get the pulmonary edema, you can get ascites, you can get elevated JVP, peripheral edemas. But remember, none of these things actually happen. The patient are usually in SIADH or euvolemic, and this is a really high concept to be aware of. So I'm going to explain this now, is that when you have SIADH, there is water retention. Like I said, there is water retention. If there is water retention, there is increased intracellular fluid volume. It will suppress the ROS system, renin-angiotensin-aldosterone system. So there is decreased aldosterone. At the same time, there is also what does normally aldosterone do? What aldosterone does is that it actually reabsorbs water plus sodium. So if aldosterone is decreased, there is no water reabsorption and there is no sodium reabsorption. So there is increased loss of sodium in this in decreased aldosterone state. and another thing that this increased expansion of the intravascular volume does is that if this is the heart and this is the ventricle and this is the atrium, it can expand this atrium and ventricle because of the increased blood that is coming to the heart. And this expansion, this stretch, releases something called BNP and ANP, natriuretic peptides, and they will also increase excretion of this sodium in the urine. So there is increased loss of sodium. There is also increased loss of with the sodium water, and so you don't get that hypervolemic state because of increased BNP and ANPs, the natriuretic peptides. So this leads to a euvolemic states because this will increase loss of sodium, and with the sodium, remember, whenever there is loss of sodium, a water follows that sodium. So whenever there is increased sodium, water is going to go there. So if there is increased urine going out in the urine, there will be more water that is going to be following that, and that results in loss of water plus sodium and resulting in euvolemic state. So that's why in SIADH you don't get hypervolemic state. So this is a really high yield concept. So if someone asks why euvolemia, just tell them that there is decreased aldosterone because of decreased ROS activation or suppression of the ROS. Also, there is a stretch on the heart, ventricle, and atrium that releases natriuretic peptides that causes natriuresis and loss of sodium and water in the urine, and that's going to cause a euvolemic state because now you're losing the water. So I hope this video was helpful, and if anyone requires tutoring, they can email me here. And if this channel helps you, you can support the channel here, and you can get my high yield step 2 CK notes there as well. Thank you for watching. Hello everyone, and welcome to another day of high yield USMLE questions. So today we will be talking about MSK. So we had a 35-year-old female presented to the office with bluish discoloration of the fingers and joint pain for 4 weeks. She also gives history of difficulty picking things with hands due to taut fingers. On examination, the patient is pale with a rash on the face, sparing the nasolabial fold. So remember, this is a malar rash. This is the malar rash, and I put in the question that it spares the nasolabial fold because it helps to differentiate it from other rashes. So if they say spares spares the nasolabial folds, they're talking about SLE. So now CBC shows hemoglobin of 9, WBC of 7, which is normal. Hemoglobin is low, so there is anemia, and also there is thrombocytopenia, decreased platelets. So remember, in SLE you get one or more cytopenias. So remember, SLE is mediated by type 3 hypersensitivity reaction, which means immune complex deposition. But the cytopenias are the only manifestation of SLE which is mediated by type 2 hypersensitivity reaction. So important. So this patient has features of SLE. This patient also has features of like picking things. So that's like scleroderma. And there is Raynaud's phenomenon. So ANA is positive for obvious reasons, and anti-UN or U1-RNP is positive. What else will you see in this patient? So remember, anti-U1-RNP is seen in mixed connective tissue disease, MCTD. So now, what else do you see in MCTD? So remember, you see 4 connective tissue diseases: SLE, rheumatoid arthritis, polymyositis, and scleroderma. This patient has scleroderma features, also SLE features. So now, what else will you see though? The answer is polymyositis. Myasthenia gravis is the wrong answer. Usually it's associated with thymoma. Remember, whenever you diagnose myasthenia gravis case, you have to do CT chest to rule out thymoma, because if you remove thymoma, patient actually gets cured. Some of the patients get cured. Hemolytic uremic syndrome, wrong answer. You get triad of like thrombocytopenia or fever, and you also get renal involvement there. Creatinine is elevated. Usually it occurs in children after eating hamburgers. There is bloody diarrhea. Bloody diarrhea due to E. coli. E. coli releases Shiga toxin. Shiga toxin damages the endothelium. Microthrombi form. Platelets are consumed. You get thrombocytopenia. Red blood cells are sheared, forming helmet cells or schistocytes, and you get hemolytic anemia, something called MAHA, microangiopathic hemolytic anemia. This is wrong answer. Here, you will not see this in this in the mixed connective tissue disease. Multiple sclerosis is the wrong answer. So I hope this video was clear. It was a quick video about the about mixed connective tissue disease, high yield for any Usmle exam. And if anyone requires tutoring, they can email me here. And also, if you want to enroll in my Stats and CSS class, you can email me here as well. It's about 20 USD, and it's about 2 hours class. And here, if anyone wants to support my channel, they can support it here. Thank you for watching. Hello everyone, and today we will be talking about another Usmle high yield question. So this is going to be important across all Usmle step exams. So today we'll be talking about cardiology. So we have a 60-year-old male patient with prior history of angina, presented to the emergency department with low blood pressure, and which is, you can say hemodynamically unstable because it is less than 90. So 80/50, pulse is 42, really severely bradycardic, respiratory rate is 13. According to the wife the patient took too many pills, but she does not remember the name of the medication. So examination of the chest shows bilateral wheeze in addition to fluids and atropine. Which of the following is given to this patient? First, we need to know which medication the patient took, like which medication caused this toxicity. So as the patient is angina, so most likely the patient took beta blocker. So it's most likely a beta blocker overdose. Everything explains beta blocker overdose here. We have a bradycardia, we have hypotension, and we have wheeze. Because remember, beta blockers can cause wheeze, can cause bronchoconstriction. So let's see what else we can give. So fluids are given for hypotension. Atropine can raise the pulse, so that's why these two are given. But in addition to these, which of the following can be given? So flumazenil, remember, is the wrong answer here. Flumazenil is used for benzodiazepine overdose. So in benzodiazepine, vitals are normal. Also, wheeze is not seen, so this is not the right answer. Soda bicarb is used in TCA overdose. In TCA overdose, you get tachycardia rather than bradycardia. You also can get urinary retention and all the other anticholinergic symptoms, like you can say mydriasis. You can get really hot skin. So that those will be the features of TCA. Also the 3 C's, coma, convulsion, and cardiotoxicity, cardio. And this bicarb is used mainly to for cardiotoxicity, to prevent the cardiotoxicity. Then with the glucagon, and this will be the right answer. Remember, beta blocker leads to decreased cyclic AMP, and it then causes all the bradycardia and the hypotension. Glucagon would cause increased cyclic AMP, and it works on different receptors, and so it will increase the cyclic AMP and oppose these effects of beta blocker. In addition to glucagon and atropine, you also give high dose insulin, and you give high dose insulin plus glucose. You also give lipid emulsion therapy, and the reason is because this is fat soluble. So also glucagon is also used for calcium channel blocker overdose. Temporary pacing may be considered here because of the bradycardia, but remember, in beta blocker overdose, it's not been shown to be as effective as glucagon or other strategies that we use for treatment of beta blocker overdose. So hope this video was helpful, and if anyone requires tutoring, can email me here. And if anyone likes the channel, they can support me here. Link in the description. Thank you for watching. Hello everyone, and welcome to another video. So today we will be talking about neurology. So it's the 42nd question in the Mediculized question bank. So we have a 30-year-old female presented to the office complaining of headache for the past 3 weeks. There was an episode of vomiting associated with the headaches as well. So medical history is unremarkable, and the patient is not using any medication except for oral acetretinoin for acne. She has not had a seizure, vision changes, or neurologic symptoms. The patient has a BMI of 37. Vitally, the patient is stable. Frontoscopic examination shows papilledema. What is the next best step? So this patient has a lot of risk factors, and also the features are very concerning for a raised intracranial pressure. So this raised intracranial pressure is in a female who is obese. So these are risk factors so far. Obese. Connect the dots. So we have obesity, and then we have isotretinoin, and then we have the female. So these 3 risk factors so far. And then there are raised intracranial pressure symptoms. So this is a perfect case for pseudotumor cerebri, also called idiopathic intracranial hypertension or pseudotumor cerebri. So remember, these are the risk factors for this is going to cause increased raised intracranial pressure symptoms like vomiting and headaches. And so we need to know the raised idiopathic intracranial pressure symptoms, idiopathic intracranial hypertension risk factors. So you can remember them by the mnemonic female toad G. So F is for female. Here, this is a female. So 1. Then tetracycline can also cause obesity. This patient is obese. Then we have the A is vitamin A toxicity. Vitamin A, remember, it's not the deficiency, it's a toxicity. If you have excess vitamin A, this patient is taking isotretinoin, that could lead to vitamin A toxicity. D is for danazol. Danazol is a drug. And then G is for growth. This is the growth factor. So some people require growth factors for some managements, and those can also get the idiopathic intracranial hypertension. Now let's talk about what we need to do here. What is the next step? So remember, whenever you have a raised intracranial pressure, regardless of etiology, like you don't know any etiology, you don't know what's going on. So the first step is always to do brain imaging. So you can do a CT scan or MRI of the brain. Either is fine. So a patient comes with the raised ICP. You do CT MRI. Let's say CT MRI is normal. Let's say remember, the reason that you're doing CT MRI is to rule out intracranial mass. Rule out intracranial mass. Now the next step should be the lumbar puncture. Remember, lumbar puncture in an adult should not be done before doing CT and MRI, because let's say you did LP before CT and MRI, and you had, let's say you did not rule out intracranial mass and the patient had intracranial mass. The LP in the presence of intracranial mass will cause brain herniation and death. So never do this unless it's an infant, let's say less than 18 months, because they have open fontanelles. Anterior fontanelle. So in that case, they can act as a pop-up valve. So in that case, you may go directly and do LP without doing CT MRI if LP is needed. But in adults, always, in children greater than 18 months and in adults, always CT MRI before LP. CT MRI should be done to rule out intracranial mass, and then you can do LP. And after LP, let's say it shows, remember, for idiopathic intracranial hypertension here, this is going to be both therapeutic plus diagnostic. So it's going to relieve the headache. Also, it's going to diagnose, because you will see increased, you are going to see raised opening pressure. Now, once the LP is done and you have diagnosed the condition, then you need to start management. So the first line management is weight loss. You're going to tell the patient to lose weight, and also you are going to start them on some medication that is going to decrease the ICP, decrease the synthesis of cerebrospinal fluid. For example, acetazolamide is a carbonic anhydrase inhibitor, and it can be used to chronically for the management of idiopathic intracranial hypertension. So it decreases CSF production. Also remember, there is another drug like topiramate can also be used. Now let's say use these drugs and the patient is still not responsive. Then you can do something called optic nerve fenestration surgery. So let's say we have this optic nerve, this papilledema here that they gave. This is going to be seen in anything that raises intracranial pressure. So it's regardless of etiology. Anything that raises the intracranial pressure will cause papilledema. Now, so opening nerve fenestration surgery. So this is your optic nerve. Around the optic nerve, you have a CSF here. CSF is here. Now, if you have raised intracranial pressures, so this will be transmitted to this space as well, around the optic nerve. So you will have there's increased CSF here, pressure here, so it's going to compress the optic nerve as well. So now what you're going to do here in optic nerve fenestration surgery is that you are going to make an incision here and drain this CSF out. It drains into the periorbital fat. So that's going to relieve the intracranial pressure. So if nothing is working, you can do optic nerve fenestration surgery. Also remember, this is also done if you have visual symptoms with pseudotumor cerebri. You may do this as well. Now, so also you can do another thing called ventricular peritoneal shunt. So this is going to constantly drain that CSF into the peritoneal fluid. So this is the overall management. So remember, if they say which cranial nerve can be damaged by idiopathic intracranial hypertension, is the sixth nerve. The sixth cranial nerve is the one that is going to be most prone to damage. anything that raises intracranial pressure, answer that it's the sixth nerve is at damage. So lateral rectus palsy, the patient is not going to be looking laterally at the side of the where this nerve, the sixth cranial nerve, is affected. So so the answer here is CT brain. I just explained it. The next step should be CT or MRI. Lumbar puncture, wrong answer. You may do it after CT once you rule out the intracranial mass. Acetazolamide, wrong answer. We don't know the diagnosis yet, so wrong answer here. If both of these are done and the diagnosis is confirmed, then you can start acetazolamide. Systemic steroids, wrong answer. It's not because of inflammation or trauma or anything. No edema is going on here. So steroids, wrong answer. Topiramate, again, you may give it in someone with idiopathic intracranial hypertension, but you need to first work up and diagnose the condition. So wrong answer. So the right answer is CT MRI. I hope this video was helpful. If anyone requires tutoring, they can email me here. Also, you can support the channel. Links will be in the description, and it helps the channel. See you in the next video. Hello everyone, and welcome to another day of high yield USMLE questions. So today we will be talking about MSK. So we had a 35-year-old female presented to the office with bluish discoloration of the fingers and joint pain for 4 weeks. She also gives history of difficulty picking things with hands due to taut fingers. On examination, the patient is pale with a rash on the face, sparing the nasolabial fold. So remember, this is a malar rash. This is the malar rash, and I put in the question that it spares the nasolabial fold because it helps to differentiate it from other rashes. So if they say spares spares the nasolabial folds, they're talking about SLE. So now CBC shows hemoglobin of 9, WBC of 7, which is normal. Hemoglobin is low, so there is anemia, and also there is thrombocytopenia, decreased platelets. So remember, in SLE you get one or more cytopenias. So remember, SLE is mediated by type 3 hypersensitivity reaction, which means immune complex deposition. But the cytopenias are the only manifestation of SLE which is mediated by type 2 hypersensitivity reaction. So important. So this patient has features of SLE. This patient also has features of like picking things. So that's like scleroderma. And there is Raynaud's phenomenon. So ANA is positive for obvious reasons, and anti-UN or U1-RNP is positive. What else will you see in this patient? So remember, anti-U1-RNP is seen in mixed connective tissue disease, MCTD. So now, what else do you see in MCTD? So remember, you see 4 connective tissue diseases: SLE, rheumatoid arthritis, polymyositis, and scleroderma. This patient has scleroderma features, also SLE features. So now, what else will you see? The answer is polymyositis. Myasthenia gravis is the wrong answer. Usually, it's associated with thymoma. Remember, whenever you diagnose myasthenia gravis case, you have to do CT chest to rule out thymoma, because if you remove thymoma, patient actually gets cured. Some of the patients get cured. Hemolytic uremic syndrome, wrong answer. You get triad of like thrombocytopenia or fever, and you also get renal involvement there. Creatinine is elevated. Usually it occurs in children after eating hamburgers. There is bloody diarrhea. Bloody diarrhea due to E. coli. E. coli releases Shiga toxin. Shiga toxin damages the endothelium. Microthrombi form. Platelets are consumed. You get thrombocytopenia. Red blood cells are sheared, forming helmet cells or schistocytes, and you get hemolytic anemia, something called MAHA, microangiopathic hemolytic anemia. This is wrong answer here. You will not see this in this in the mixed connective tissue disease. Multiple sclerosis is the wrong answer. So I hope this video was clear. It was a quick video about about mixed connective tissue disease, high yield for any USMLE exam. And if anyone requires tutoring, they can email me here. And also, if you want to enroll in my Stats and CSS class, you can email me here as well. It's about 20 USD, and it's about 2 hours class. And here, if anyone wants to support my channel, they can support it here. Thank you for watching. Hello everyone, and welcome to another day of high yield USMLE questions. Today we will be talking about endocrinology. So we have a 60-year-old male presented to the office because of a mass in the left thyroid gland. He does not complain of any symptoms, but he noticed the mass 2 weeks ago while showering. Widely, the patient is stable. TSH is 0.9, which is normal, and then ultrasound shows a 2 centimeter mass, which is big. fine needle aspiration of the mass is done, which showed clusters of follicles. Left thyroid lobe excision is performed, which of the following would suggest follicular carcinoma. So those who've studied follicular carcinoma, they would know the histology finding of the follicular carcinoma, and they will just answer right away. But first, let's talk about how this question is kind of built. So first, this patient came with a thyroid nodule. So remember, whenever someone comes to the clinic and they have a thyroid nodule, the first step is to do a TSH-R ultrasound. TSH-R ultrasound. Now, let's talk about what would suggest, like, there are two pathways that you can go down. Like, which investigation you're going to perform depends on the results of these two tests. So let's say, TSH is low. If the TSH is low, that means that actually that was functional. The thyroid nodule, like if this is a thyroid gland, and let's say this is the nodule, this was functional. So if this was functional, which means that it was producing T3 and T4. If it was producing T3 and T4, it would go to the pituitary and inhibit the TSH. So that's why TSH was low. So whenever you have hyperthyroid or hyperfunctioning thyroid adenoma or a nodule, you are gonna go and do a thyroid uptake scan. It's a thyroid radio iodine uptake scan. Now, there can be two types of nodules on a radio iodine uptake scan. One are called the hot nodules, the other called cold nodules. So hot nodules means that they are functioning, they're super functioning. So if you give them a radioactive iodine, the iodine is taken up by this adenoma or is this nodule, and this is why it lights up on the scan. So this is why it is called the hot nodule. So now if you have the hot nodule, the next step is in hot nodule is to treat the hyperthyroidism. That's it. Now, if it is cold, it means it's not functional. So if it's not functional, that usually means it could be cancerous. So the next step should be FNA, is to do FNA. Remember, FNA is one of the investigations that you do if you have a thyroid mass to look for any cardiac cancer. But we will talk about, there is one limitation of FNA that you will know. Now, so in let's say TSH is normal or the TSH is high. This means that this is not functional, because it either means that the T3 T4 is low, which means it's gonna feed back on the hypothalamus, on the pituitary, to increase the TSH. So it will increase the TSH here. The TSH is increased or normal. So if it is increased or normal, it means it's not functional. You're going to FNA right away. So that this pathway is very important for both step 1 and step 2 to know. Now, let's talk about what happened here. So remember, like I said, if you usually do FNA, but there is a limitation to FNA. Remember, FNA cannot differentiate between a follicular adenoma, which is a benign tumor, from follicular carcinoma, which is a cancer, which is a malignant tumor. Now, what happens here is that in follicular adenoma, what happens is the tumor is encapsulated. Let's say this is the capsule of the adenoma, or the follicular adenoma, and then you have a lot of these follicles within it. So remember, they do not cross this capsule. Now, what happens in follicular carcinoma? So in carcinoma, you will have this. So it will be the same capsule like this, but what happens here is that these tumor cells, these follicles, they can actually grow through. They can grow and break through this capsule. So there is capsular invasion. Now, so if you, let's say, do FNA, it cannot differentiate between follicular adenoma and carcinoma. The reason is that it's a small it's a needle. So it's a needle, so it will come here like this. So it will only show this part of the capsule, nothing else. So let's say if you do FNA on this one, so how would you differentiate between this and this? Because both will appear as if they have capsule. You are skipping this part. So remember, whenever you have you're suspecting follicular adenoma, you should do excision of the entire glands to look for the entire capsule. So remember, it cannot differentiate between adenoma and carcinoma. For that, you need to do complete excision, and this is what it's done here. So the final aspiration was done, and it showed clusters of follicles. So it could be cancer or it could be adenoma. So that's why you did excision to know if it is a carcinoma or a adenoma. So remember, like I said, if the entire excision shows capsular invasion, that means that it is a follicular carcinoma. So cells spreading through the capsule is the right answer here. Now, Let's go over the answer choices and what they represent. So the Hertha cells. Remember, Hertha cells are weird eosinophilic, weird pink eosinophilic cells that you will see on a histology slide of someone usually with Hashimoto thyroiditis, which is an autoimmune thyroiditis, most common cause of hypothyroidism. And remember, whenever you hear the word thyroiditis, there is always first initially the release of the stored thyroid glands, and then there is a hypothyroid phase. So first there is a hyperthyroid phase, and then it goes down, and there is a hypothyroid phase. And this hyperthyroid phase in thyroiditis is because of inflammation releasing the preformed thyroid hormones. Now we have the second option is a cell with nuclear grooves. So this is a papillary carcinoma. Remember, papillary carcinoma is the most common cause or the most common thyroid cancer, and also it has excellent prognosis, usually associated with radiation exposure, childhood radiation exposure. Like if you watch the web series of Chernobyl, so that's where that's actually caused a lot of the papillary carcinomas, but the prognosis is excellent here. You also see orphan NEI nuclei, which you may know, and also you see the psammoma bodies in the papillary carcinoma. So this is also wrong answer. This is also wrong answer here. The last one is germinal centers. So remember, if the Hashimoto thyroiditis will also show a germinal center. So these Hürthle cells in germinal centers are some of the things that you will see in Hashimoto thyroiditis. This patient has no hypothyroidism, no hyperthyroidism. There is no autoimmune disease going on, so it doesn't look like Hashimoto thyroiditis. On top of this, they are looking for follicular carcinoma finding. So this is particularly helpful for Usmle Step 1 students. And if you like the content, you can subscribe, like the channel, and like this video as well. And if you want to support the channel, the link will be in the description. If someone requires tutoring for any Usmle Step exam, they can email me here. Thank you for watching. Hello everyone, and welcome to another day of high yield USMLE questions. Today we will be talking about gastrointestinal. So we have a 40-year-old male patient presented with epigastric pain for the past 3 weeks. The pain is exacerbated by eating. The patient has smoked 1 pack of cigarette for a day for the past 5 years. The patient is allergic to penicillin. Family history significant for mother with diabetes and father who died of pancreatic cancer. Physical examination shows a tender epigastrium. Stool for H. pylori is positive. Which of the following is the management? So epigastric pain is common for someone with peptic ulcer disease, which this patient has, and if they say it is peptic ulcer disease, can include either a duodenal ulcer or a gastric ulcer. If it exacerbates with eating, it's gastric. If it's relieves with eating, it is duodenal. So if it's relieved with eating, the duodenal ulcer relieves with eating, so the patient will eat a lot and will have weight gain. In the gastric ulcer, because with eating it exacerbates, so they will not eat and lose weight. The most common cause of peptic ulcer disease is H. pylori, and this patient has a positive test. This patient, one of the things that a student gets confused with, confuses this peptic ulcer disease with is GERD, gastroesophageal reflux disease. So remember, here you have retrosternal pain or burning, retrosternal. In peptic ulcer disease, you have epigastric pain. So this is important information to know. And then this patient has a smoking history as well, which can also contribute to PUD, as a distractor, because in step 2, usually, in step 1 and step 2, they can, give something to confuse you. For example, here, they give history of father with pancreatic cancer to kind of make you think that it could be pancreatic cancer or something, but it's not. Here in this question, they clearly said that H. pylori is positive, and then you need to just know the management. The management is either the triple therapy or quadruple therapy. So if the triple therapy doesn't work, you switch to quadruple. So in the triple therapy, just know the PAC is the mnemonic, and we have the here we have PPI, and then amoxicillin, and then clarithromycin. So instead of the amoxicillin, you can actually use metro. So it's either amoxicillin or metro. In the quadruple therapy, you have PPI again, and you have 2 antibiotics like tetracycline plus metro, and you have metro plus tetracycline, plus you have bismuth sulfate. So this is where you use this is the regimen for the quadruple therapy. Here, this patient, omeprazole, which is a PPI, A is for amoxicillin, and PAC is clarithromycin. But this seems right, but the thing is that it is the wrong answer because the patient is allergic to penicillin. So this is the wrong answer. Omeprazole, clarithromycin, metro. This is the right answer. There is no amoxicillin here, so we could use it. This patient is allergic to penicillin. So remember, there is amoxicillin allergy chance as well in this patient. So you are going to avoid amoxicillin. So amoxicillin options are out. This is out. And then ceftriaxone and vancomycin are not given. They're only used, for example, for ceftriaxone, remember, for CNS, like meningitis. Vancomycin usually used for if you're suspecting staph infection. So, or gram-positive infections. So hope this video was helpful. And if anyone wants tutoring, they can email me here. I've helped a ton of students for Usmle's step 1, 2, and 3, all with the step exams. And if you like the channel and if it's helpful, you can support the channel here. Hope this video was helpful. See you in the next.